The next session is societal guidelines. My co-moderator here is my very good friend and the best boss I've ever worked with, Dr. John Inadomi, who is the current chair of medicine at the University of Utah. So he will be introducing our first speaker.
Great. Thanks, Joo Ha. Actually, it's you heard a little bit about Joo Ha. There's an old saying: you never play poker with a guy named Doc. Never bet at golf with a golfer named Joo Ha. He'll clean out your wallet. So he's quite good. Anyway, I'm really excited to kick off this session. Our first speaker, Dr. Ernst Kuipers. I've known Ernst probably a couple decades. First as a division chief at Erasmus and the president of Erasmus University, and then also visited him when he was the Minister of Health, the entire country of the Netherlands, which is a bit of a crazy experience for him. We can hear more. And currently, Ernst is on the governing board of the National University of Health System in Singapore and the vice president of research at Nanyang Technology University in Singapore. So love to hear your perspective about societal guidelines. So thanks so much, Ernst.
Thank you very much, John, and it's a real pleasure to be here. And by the way, the job for the National University Health System was in the past, but now it's indeed in Singapore with the Nanyang Technological University and its healthcare cluster. But it's a real honor to be here and also to talk about European guidelines on gastric precancerous lesions. And I'm very glad with the remark that has been made repeatedly in the morning that the meeting is also, as a summit, really intended to bring the field forward. Now, I've been working in this field on gastric cancer already more than 30 years, and I think that we definitely have made major progress, but have to make further steps very importantly. Now, when we do all this, we do not live on an island. We work in a much larger setting of clinical medicine, public health, and policy making. So when talking about guidelines, I would first like to take the liberty to zoom out a little bit to help us realize why and how we do all this. So this is a slide from a study that you're all familiar with. It's called the Global Burden of Disease Project. And it showed that in an earlier publication now 9 years ago, that over a period of a mere 23 years, our world life expectancy had increased with 6.3 years. If you're not immediately impressed, just think of it. For 23 years in a row, every week, our life expectancy as a world population increased with about a day and a half. You see to the right that this happened in all the different continents and for improvement of outcome due to a whole range of diseases, cardiovascular, infectious diseases, and cancer. And in fact, if you think about how this came about, it's basically like the movement of a centipede. Every intervention that we did is like the movement, the step of one leg of the centipede. It hardly seemed to affect the movement of the animal at all, and yet every step was important to make. Unfortunately, however, there were also quite a significant number of limitations, and I'll give a few of them just in a random order, starting with the financial impacts of this, which you see here on the x-axis is a whole range of different countries. And for every individual country, OECD data, over a period of more than 20 years, you see that the health spending growth per capita in red outpaced our GDP increase. In other words, yes, we improved significantly, but also at a significant cost. Now, one other effect is that healthcare up until today remains extremely labor intense. It means in many countries, like mine in the Netherlands, at the moment approximately 1 in 6 people with a job, 1 in 6, works in healthcare. And at the pace at which we've been developing this, it will be 1 in 5 in 2030 and 1 in 4 in 2040, while we're already facing significant deficits. So it seems that this is not sustainable. Now, and then the next one is that, yes, we have increased our life expectancy, but if you look at studies which actually reported on healthy life years, there was either no change or actually, in most countries, a decline. And one important reason, of course, is that we've been discussing, also here today, a lot on focusing on interventions in disease instead of focusing on preventing of disease and also changing our behavior, as very nicely illustrated by this statement from George Burns, who lived to become 100 and said, if I had known I was going to live this long, I would have taken better care of myself, with a cigar in one hand, and you can't see it but a glass of wine in the other. So we have quite some issues. And another issue is that up until today, almost everywhere in the world, we see this, despite all the improvements in healthcare, very significant inequalities and inequities in the outcome of disease. Illustrated, it has already been mentioned a couple of times, also here in the US. This is one other publication comparing the age-standardized incidence rates of gastric cancer in women from indigenous populations versus national estimates, and again showing that the indigenous populations everywhere in the world, the incidence rates and also the mortality rates, not in this slide, are significantly higher. Now, why is this relevant? Because it's already been known that gastric cancer is a common disease and is also associated with a very high mortality, thus showing in this graph from a publication in New England Journal 5 years ago that it's close on the XY axis, with incidence and mortality almost being the same. In other words, 100% of the people diagnosed with the disease about to die, and it's also on the upper right, meaning the incidence and mortality are high. Now, we are faced with this in gastroenterology in many different ways, and with the introduction of endoscopy and the development, we've now, across the GI tract, known to identify pre-malignant lesions and look at their cancer risk and come up with guidelines for the surveillance and the intervention, etc. But surprisingly, gastric cancer was very, very late and very slow. And this is even more surprising if you look at where it all started. It started actually with studies looking at atrophic gastritis and gastric cancer risk. And I like to remind you of these cohort studies for development of gastric cancer in patients with multifocal atrophic gastritis. If you, for instance, look at the top study, published in 1966, wow. And already at that time with a follow-up of 12 years, meaning that the study started in the 1950s, not with gastroscopy, but with fluoroscopy-guided blind biopsies. But already at that time showed that the gastric cancer, as a proportion of the number of subjects per year, was 0.6 to 0.8. Keep in mind, we heard a study this morning about approximately the 0.3. So these original studies, which were the basis for polyochoria, were very, very similar. So we knew pre-malignant lesions and gastric cancer risk. And we also knew, and this is 30 years ago, that infection with Helicobacter pylori is carcinogenic to humans. You see in this picture on the lower left, the front row left, polyochoria with an arrow. You see behind him, the guy with the big beard is Francis Maigret, who did a lot of work on Helicobacter studies. And if you look at somewhere in the middle, just to the right, this guy with a very ugly tie, and at that time, still some hair on his head, this was me 30 years ago. So if you believe that I never had any hair, well, here is at least a demonstration that I did. And Paul Moyetti and Julie Passanet can confirm. Yeah. So why were we so low? The evidence was there starting with gastric cancer, prior to Barrett, prior to colorectal, etc., etc. Well, one was that we were sort of, Charles already mentioned it, we were taken on the wrong path. Because here in the US and also in Europe, you see that for a range of different countries, the incidence of gastric cancer ever from long before the 1980s actually had steadily declined. But also pay attention to the red arrow. The countries with the lowest incidence, Shaila already mentioned it, have basically been stable for the past 25 years. Whoa, so something is happening here and something needs to change. In fact, this is similar data from the US, age-related time rates in the US incidence of gastric cancer, same time period, and you see that in particular in the younger populations there was actually an increase, which made at the time Marty Blazer and Yu Chen come forward with editorial A New Gastric Cancer Among Us, being corpus, young and female predominant. So there was really a time to come up with guidelines. And that's why Mario Dines Ribeiro and myself in 2012 brought together a group of experts from Europe and came up with the first guidelines on management of precancerous conditions and lesions in the stomach, which we abbreviated to MAPS. Sorry for this abbreviation, but this is how it became known. And you see that 7 years later, we came with a follow-up, the second MAPS, and very recently, we completed the third, the update. It says 2025. The manuscript was completed this week, and I'm very happy to give you a presentation in particular on those guidelines. So these guidelines were focused on atrophic gastritis, gastric intestinal metaplasia, and dysplasia. Of course, we also had other European guidelines, like Matthew Banks, the British Society of Gastroenterology guidelines on diagnosis and management, focused in particular on the UK, but also on atrophy and metaplasia. We have the Helicobacter pylori management guidelines, which traditionally focused on HP and HP gastritis, but in the most recent one published 2 years ago in Gut, it also focused on atrophy and metaplasia. I'll mention a little about this. And there was a beautiful publication earlier this year from Massimo Ruge and colleagues, including myself, which really looked at the international perspective on gastritis, which is also a guideline. Now, so these examples were luckily followed with many others, and I'm glad to hear more also about the most recent updates of the US. But this is a total overview. So coming to these guidelines, there are obviously many different paths in which you can look at gastric cancer prevention, either primary prevention, secondary, or tertiary. And some of these have already been discussed. And first, I'd like to focus on primary prevention, in particular H. pylori screening and treatment. Now, we've heard already from from Paul, the beautiful overview. This is the former publication from Ford and Paul and colleagues, but already at that time showing that HP eradication for gastric cancer has a significant impact and actually prevents almost more than 1/3, almost half of all the gastric cancers. So the Maastricht-Florence guidelines make a remark on this and say, for one, H. pylori eradication eliminates the active inflammatory response. In other words, it heals gastritis, and it prevents further progression to atrophy and metaplasia in chronic non-atrophic gastritis. And the guideline then continues with HP eradication offers a chance for gastric cancer prevention. Sorry for it, this is the literal statement. It offers the chance. And finally, HP eradication is most effective for gastric cancer prevention before the development of severe chronic atrophic gastritis. And we already just heard before the break that this is based on a range of different studies. So far with respect to the primary prevention. The MAPS guidelines do not focus on that. I mentioned they focus on atrophy and metaplasia and management of that. So that brings us to secondary prevention and first screening and detection of subjects with pre-malignant gastric lesions. Well, we heard already that there are many different studies. One of the most beautiful ones from Korea, I won't repeat it, but really showing that endoscopic screening and surveillance of people with atrophy and metaplasia has a very significant impact in terms of gastric cancer and gastric cancer survival. So the Maastricht-Florence guidelines now in the last update, I mentioned first they just focused on HP gastritis and eradication of HP, but they do mention it in their last update and say screening modalities for gastric cancer prevention, either being non-invasive or endoscopic, combined with colorectal screening is an opportunity. And then they list HP antibodies and pepsinogen 1 as an option with the recommendation to eradicate Helicobacter if serologically positive and to perform endoscopy if serum pepsinogens are low. And mind you, these are European guidelines with a focus on the world. But as already shown this morning, Shaila also did it, if you look at the picture for Europe, then the incidence of gastric cancer may be relatively low in countries like Germany and France and the Netherlands and Denmark, but is still very high in Eastern European and Baltic countries. So the MAPS guidelines, as well as the BSG guidelines on this same topic of secondary prevention and atrophy and metaplasia say we recommend against population-based endoscopic screening for atrophy and metaplasia in gastric cancer in countries with the gastric cancer incidence, gastric cancer ASR below the 10 per 100,000, But in those with higher ASR, screening at 3 to 5 year interval can be considered based on resources and cost effectiveness. And the BSG focuses on the UK population, which does have a lower than 10, and recommends against population screening for gastric cancer in a UK population. Well, this has been shown. Which countries are we then talking about? If you look at the higher ASR, I already mentioned there are many, but including in the more Eastern European part, but also, for instance, look at Portugal. And mind you, in many populations, also, for instance, in the Netherlands, if I take Rotterdam as a city where more than half of the population is first and second generation immigrant, many people coming from countries such as Turkey and all over, then we see this same distribution, and there should be populations where we should focus on, even in the Netherlands. So what about HP and endoscopic screening in first-degree relatives of gastric cancer patients? Again, the same two guidelines, the MAPS, the most recent update, submitted for publication soon, and the BSG. The MAPS first suggesting that H. pylori non-invasive screening and eradication between the ages of 20 and 30 for first-degree relevance of patients with gastric cancer. And then looking a little later in life and saying endoscopic screening in these same subjects at the age of 45 years or 10 years before the age of diagnosis of the affected relative. And a similar statement from the BSG guidelines, as you see in the last bullet. Now here we come to an important one. And it has already been discussed, and nevertheless I stress it once more. I think it's very important that the MAPS guidelines recommend that a diagnostic gastroscopy should include adequate assessment for precancerous conditions as well as gastric cancer. It's a very simple statement, but it's not equivalent to a 1-minute procedure where you identify the pylorus and the angulus and see whether there is an ulcer, yes or no. It doesn't take half an hour, but it just means that you know what you look for, that you are trained. It's not very difficult. It's not more difficult than recognizing a Barrett's esophagus or an adenomatous polyp in the colon, but you have to know it. And so the MAPS also recommends training in the endoscopic diagnosis of gastric precancerous conditions and lesions. And a study from Marius Dino Ribeiro and his colleagues, Pimentel, have shown that this training is actually highly efficient in very rapidly increasing your diagnostic rate. So we already in the past, I didn't include it in the slide, also came forward with a proposal to simply set a minimum limit of detection rate of gastric intestinal metaplasia during your endoscopy, similar to an adenoma detection rate. And then the BSG also recommends the routine use of imaged enhanced endoscopy. Now, why is this important? Well, for instance, this is a publication now 10 years ago, which looked at 10 different studies in which people had received a diagnostic upper GI endoscopy and then were followed, covering over 180,000 endoscopies with a 3-year follow-up. And what you see is that there were almost 3,800 upper GI cancers diagnosed, of which 12% had been missed at the initial endoscopy, but only became apparent when people developed symptoms and came back. Now, 88% of those were missed in the stomach, not in the esophagus, but in the stomach. The authors conclude in their paper, this is a relatively uncommon event occurring in 1 in every 398 endoscopic procedures. So it's a beautiful study, but I totally disagree with the conclusion. And in fact, if I would, I don't have the time now, but if we make the translation to, for instance, mammography in breast cancer screening, missing a lesion in 1 of 400 procedures, or Barrett's esophagus, or take colorectal cancer after a colonoscopy, we would find this rate totally unacceptable and send the clinician back for further training. And yet we do accept it in gastroscopy, and we should not. So we know, and we have been identified already what we look for. And let me just point out this beautiful paper. Schuyler was the first author in gastroenterology now 3 years ago, where we put a lot of emphasis on how to actually do this. So then we come to the combination of secondary and tertiary prevention, but now looking at surveillance of people who have been identified. So how common is this? We don't really totally know, but there is a couple of studies in Western populations which, in the group which we just mentioned, people who came for a colonoscopy didn't have any specific reason or symptoms to undergo an upper GI endoscopy, but as part of a study were asked to undergo. And then you see this was a Dutch study which we performed quite some years ago, which is shown here in yellow, and a German study also. And you see the people in the Dutch study, the mean age was 53 years. The German studies where they were a little older. But just focus on the prevalence of atrophic gastritis and intestinal metaplasia of any grade. Basically showing that these are still common conditions. And this is a similar study from the US, published a few years ago, which shows basically in different subgroups of the population that indeed this is very, very similar. So why is this relevant? Again, I already mentioned these very old studies, like the Finnish one from 1966. Remember the 0.7, 0.6% of the population annually being diagnosed with cancer after a diagnosis of atrophic gastritis. This is a study which we published now quite some years ago, looking at time-related progression of premalignant lesions to gastric cancer in approximately 98,000 Dutch subjects with atrophy and metaplasia. And just look at the red arrow, which was intestinal metaplasia of any grade after 10 years, approximately 4% or 0.4% per year. Remarkably consistent with all the previous studies. Now, is this relevant? Yes, it's very relevant. This is, for instance, the association of colonoscopy adenoma findings with long-term colorectal cancer incidence. And look at the rate after finding an advanced adenoma in 15 years, 2.5%. Okay, so we do all these emphasis on follow-up, and I can show you the data from the Barrett's, etc. It's all the same. So gastric cancer, atrophy and metaplasia is not a lesion with a lower risk than having an advanced adenoma or a more extensive Barrett's esophagus. It's in the same range. So then we come to these the MAPS guidelines, which suggest that systems for histological staging of atrophy, or preferably IM, can be used and integrated with endoscopic information. Recommends that patients with extensive endoscopic changes, and see the OLGA, but in particular the OLGIM 3 and 4, should be followed with high-quality endoscopy every 3 years, and recommends against any tailored surveillance strategy based on other factors such as genetics, birthplace, ethnicity, etc., once you have the advanced intestinal metaplasia. I don't have to repeat this, like OLGA and OLGIM, or the histopathology which comes to that. But then if you can do a comparison with a range of different guidelines, whether the Asia-Pacific, the Thai, the Taiwanese, the European, the BSG, and the former AGA, and also this REGAIN, which I mentioned, you see that basically nearly all of them recommended surveillance in people with advanced atrophy and metaplasia, with a follow-up usually around 3 years, sometimes also extending a little shorter or longer. The evidence is variable, but the strength of the recommendation in most that graded is strong. So other measures in these subjects, again, the upcoming MAPS, the second revision of the MAPS recommends HP eradication. I already mentioned that. Against testing for other microbiota. Smoking cessation, of course. Low-dose aspirin can be considered, but the evidence is very limited, and recommends against the use of other specific drugs or supplements. And this is in line, as mentioned already this morning, with new recommendations and guidelines from the European Union, which really focus on, for the European Union as a whole, intensify and augment, expand cancer screening, and it was deliberately mentioned to include gastric cancer. So, I mean, guidelines are nice, but are they also then really being adhered to in clinical practice? Here the evidence so far is very limited. I'll give you 2 studies from Europe. In Italy, one study which reported that 90% of the endoscopists adhered to the MAPS biopsy protocol. And in the Netherlands and the UK, a study 1 year later which looked at and reported that just over half of patients who were diagnosed with atrophy and metaplasia, in particular more advanced, were adequately surveyed. So what do we know? We know a lot about gastric cancer surveillance. It remains common, high mortality, marked inter- and intra-population differences, and changes over time with differences between generations. We know about the etiology, Helicobacter, the histological cascade. We know about prevalence and progression rates, endoscopic recognition and prevention methods. But we do need more research to optimally risk stratify who is most at risk and what is their actual risk, optimal prevention strategies, including interval, endoscopic recognition, including impact of training, and in the quality measures. And we have to realize that there is a long decline in incidence of H. pylori and gastric cancer. It's a field lesion instead of a focus lesion. Endoscopically more difficult to recognize, focus on surveillance instead of endoscopic intervention, and lack of sufficient long-term surveillance studies. Thank you very much.